what fabulous information presented by Lee and Bob, and the incredible importance of surveillance in detecting work-related illnesses and non-occupational chronic conditions. And so there are a few questions that have been developed for you. And let me ask, actually one question for Bob is, and I think this is something you can riff on, which is some surprise about the employer not giving health insurance to the individual who contracted silicosis and was so ill. And so the question is, why didn't the employer give health insurance to people who are at risk for these occupational illnesses?
Thanks, Christina. I saw that question. I think it came in from Mitch Steiger. And I also responded in the chat. Most of the workers in our most of our cases, and this is going to be published as well, this information, either did not file a workers' compensation claim or consider themselves independent contractors in which they're doing a job and getting paid cash to produce the countertop. So if you're an independent contractor, you're not covered by workers' compensation insurance. Workers' comp claims were not filed because the workers are afraid of retaliation or not being able to find a job in this network of small stone fabrication shops. Because a lot of the jobs are through word of mouth, through relatives and friends. And the cost of their care, which is very expensive, upwards of $1 million for a lung transplant, that is being paid for by the taxpayer, by Medi-Cal, the Affordable Care Act. It's probably going to run into several $1 million when we're going to total up in our series the cost shifting, because I think it's a very important point and a very important argument to make from a policy level. So, you know, thanks, Mitch, for the question. There have been some very interesting research papers linking occupational injury and disease to Social Security disability benefits and the cost shifting that ultimately occurs that runs into the many billions of dollars a year.
Yeah, just so critically important that we get coverage so that people don't have to make a choice between their the cost of treatment and their life.
I have to just say one other point, Christina, is that we are fortunate in California. Undocumented immigrants can get what are called limited Medi-Cal, limited coverage under the Affordable Care Act. That's not true in many other states in the United States. So, you know, I wake up in the morning, as I say, I feel like, well, California has very good social policies when it comes to this because we have many undocumented immigrants in our workplaces.
Yeah, we have to do that. Monique Hussein asks the question, how is it being determined whether chronic conditions are work-related? And I just think this is such a beautiful question because, you know, there's a lot of judgment involved in this. Lee, do you want to take that on?
Yeah, I love that question, and in part because I don't have a good answer. And you probably heard the way I was speaking about this, that I was using air quotes when I talked about non-occupational and occupational conditions. You know, screening can just do so much, right? So at a screening level, you've identified the suspected relationship between, you know, for some health condition. But then, frankly, it has to go a step further. It's unusual for a screening program to be diagnostic or for it to be able to collect enough information to make a determination about whether a particular patient's health condition is or isn't work-related. So, you know, I think we have to acknowledge that as a secondary prevention measure, doing screening programs have significant limitations. Now, on an epidemiologic basis, at some point, you could argue that it could be possible to use the exposure information we have about these workers and their work conditions and relate it to their risk for conditions that we might, reflexively as doctors not attribute to the workplace. COPD, asthma, these are great examples where we know a substantial percentage of people who have COPD, which as a pulmonary doctor, you're trained to just say, well, that's smoking and move on. If 15% or so of COPD cases are actually work-related, who's making that connection of what's considered to be non-occupational versus occupational? It's a big mess for us to try to do that. But it's the right question, and something that I think if we had national surveillance and if we had better exposure information, and those are big ifs, we could do a better job of establishing causal or at least strong associations. Yeah.
The next question is for actually either of you or both of you to answer, and it's really about how are exposures and surveillance invisible to us? Because those who become sick do not have health insurance or aren't covered by workers' comp. With the vast amount of undetected work-related illness for workers without traditional employment, such as gig workers and ICs, are we anywhere close to understanding what the work-related illness and injury load is for the American workforce?
I'll give a quick answer.
Go ahead, Lee.
I'm gonna take this first. I'm gonna start with the hell no response. And just take, for example, probably the most common disease of latency related to work, and that would be noise-induced hearing loss. What proportion of Americans, whether they're in a gig job or any other job, who have had significant work-related noise exposure have been identified with that condition, which may take years to manifest, and may in fact start to have a blurred crossover point with hearing loss associated with age. Bob, what's your take besides hell no?
I would say maybe that because the last decade, we've had electronic health records. And I think when it first rolled out, I almost quit and retired because I couldn't imagine that I was going to use an EHR, go from my paper chart to an electronic health record. But now it actually, I think, is a great asset to being able to coordinate and track on a individual doctor-patient level, but also to be able to pull records and to do data retrieval more easily. And I think there's actually a lot of opportunity there. We just got to do more work. Among other things, to get diagnoses, we can get some narrative medical information. If healthcare providers started asking industry and occupation, and we recorded that in electronic health records, then I think we wouldn't be as dependent on employer records, because I think my view is, honestly, we have a permanent shift in the nature of work. That precarious temporary gig work that we've been covering is going to be a feature. And because of that, using the traditional injury and illness tracking systems that rely on workers telling their employers who are putting it on OSHA logs, we need to supplement that. We need to think of other systems.
Yeah, well, it's really challenging. And you and I have been talking about, the if, if doctors would only put someone's occupation in the electronic health record, and it's still not happening.
Right.
So there's some barriers. Now, there are countries, in Scandinavia, and they're much further along in terms of being able to do what, you and I would dream of doing with our EHR. But I think that I love your optimism. I'll just say that. I love your optimism. But here's my question. As we have tied it to the gig workers, we all across our lifetime of work have a range of exposures of different length, duration, and intensity. My industrial hygiene friends like to talk now about total exposure health. How do we create those comprehensive maps of a lifetime of exposures to date that would allow us to connect that in a meaningful way to someone's health conditions that they've developed?
Excellent question. And we'll leave it there. Thank you so much to the work that both of you are doing. That's incredibly important. And we hope it will spur more action and more money and more insurance and more solutions in the future. Thank you for taking the time to speaking with us today.